Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha from Roots Community Health Center, reporting for the week of September 13th, 2021. As health professionals rooted in Oakland, serving some of the people most vulnerable to getting and suffering from COVID-19, we are here to cut through the noise to give you information you can use to make choices that will keep you, your loved ones, and your community as safe as possible. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. By way of update, nationally, as of September 12th, 2021, there have been about 41 million cases of COVID-19 and 660,000 COVID-19 deaths in the United States. Over the last 14 days, you can see the daily cases, which are those gray lines, and the 7-day average, which is the black line. And you can see that daily new cases have decreased slightly by about 7% over the last 14 days. And it looks like maybe that's a leveling off, or perhaps even coming down. This really remains to be seen. Of course, we don't want to level off at this high of a case rate, so hopefully this signals coming down. But we will be keeping an eye on this. If you take a look at U.S. daily deaths, which we know that deaths do trail behind cases, and those have increased by about 27% over the last 14 days. And so we'll be keeping a close eye on this. I think it's worth noting that in other parts of the world that have had Delta surges, that some of them have come down quite nicely and then gone right back up. So this is just something for us to keep in mind, that we remain on the COVID roller coaster. Currently, about 54% of the total population is vaccinated nationwide. So this is very far from the thresholds that were initially set around herd immunity. And I think that that goal has become elusive. I will talk about that towards the end. And in terms of Alameda County, we now have 112,286 cases. This is up a little over 10,000 compared to when I reported 2 weeks ago. And deaths have also increased by 21. We now have a total of 1,323 people in Alameda County who have lost their lives to COVID-19. In terms of vaccination, we continue just going up, which is great. We are now at almost 90% of those 12 and up with at least one dose, and about 76% that are fully vaccinated. And again, both of those percentages are for those 12 and up. And Oakland is just slightly behind at 88% and 74% respectively. So doing our rough math, trying to back out those under 12, we're really not that much higher than the national average. So we're at about 60% of our total population being fully vaccinated. So today I want to first start by reviewing some of the highlights of the Advisory Committee for Immunization Practices. And remember, this is the 15-member expert panel that gives recommendations to the CDC on immunization practices. And they met on October 30th, and one of the things that they did was to vote to recommend the Pfizer BioNTech COVID-19 vaccine for individuals 16 years of age and older. And you'll recall, and I went over this in great detail a few weeks ago, but Pfizer has received its full biologic license, and it has been approved for regular use by the FDA. But this step here, where the ACIP makes the recommendation, is important because what follows is that the ACIP will provide official vaccination schedule to the CDC to adopt, so that it will be much like other vaccines adopted in both the pediatric and the adult vaccination schedule. And what Pfizer is working on now, and we are all awaiting these studies, are their trials in children. And the way that the study is designed is that they're looking at these groups separately, of children age 5 to 11, children age 2 to 5, and then 6 months to 2 years old. And they may later look at under 6 months of age, once they establish the safety in that young age group. And so they're looking at different dosages for these different groups. And actually, the FDA asked the manufacturers to increase the sample size of children in the trials, which I think is a really good thing. Part of this was in response to some of the early signals that we are seeing around myocarditis. And so they wanted the trial to be much larger so that we could take a better look at what the impact is, particularly as we go into these younger age groups. So this may delay the process a bit, but maybe not. Pfizer was on track to be submitting their emergency use authorization sometime in September, October, and then it will take a little bit of time for that to be reviewed. So we may be looking at a December timeline for children age 5 to 11. And then after that will come the 2 to 5. And then after that, the 6 month to 2 years. So we're looking, I'm sure, into 2022 for those. So you'll recall that the White House came out a few weeks ago and made an announcement regarding boosters. And I reviewed this in some detail in the August 24th briefing. You can find those archives at rootsclinic.org. And I mentioned that neither the CDC nor its advisory committee nor the FDA had actually come out with this as a recommendation. And so the data had not been reviewed, but that I would be waiting to be able to do that review. And the ACIP did indeed cover this in the meeting on the 30th. And so just by quick review here, there's a difference between an additional dose and a booster dose. And so an additional dose is really for those who have immune compromising conditions or on immune suppressing medications. So folks with cancer, people on high dose steroids and other medications, that we are concerned that the primary vaccine series did not provoke a significant enough immune response. And so therefore an additional dose would be needed for those people to be considered fully immunized. And so this is very different from a booster dose. A booster dose is a dose after the primary series when we think maybe that the initial response was fine, but maybe it wore off after time. And once again, we don't have an official recommendation on this yet. This is something that was stated by the White House and really appears to be as a result of some studies that have happened in other parts of the world. And I think a concern that is a combination of perhaps there's waning immunity over time, but also we're dealing with Delta being a different strain. And so are we just going to need boosters in order to give ourselves that needed extra advantage, or are we not there yet? So the ACIP took this up, and it's worth noting that this wouldn't be the first vaccine that requires a multi-dose series in adults. And so here's a few examples that they reviewed in their meeting for the shingles vaccine, hepatitis A and B, and HPV. And these are all either 2 or 3 dose series. And so what happens is that in general with vaccines, the first dose kind of primes the immune system. And then the second dose really kind of ramps things up so that you can produce larger quantities of antibodies. And the timing of this for the particular emergency that we're dealing with now, the interval was 3 to 4 weeks. This was determined to be a good interval, but remember that we were also weighing out multiple considerations, including the fact that we're in an emergency, a public health crisis, and we wanted to get people fully vaccinated as soon as possible. And so we sort of always knew that there may be a need for yet another dose. And it's worth noting that just because we may need an additional dose or a booster dose, doesn't necessarily mean that we're going to need annual boosters. It is really about getting the optimal immune response from that primary series, and do we require a boost or not. And again, this is turning out to be a little bit complicated by the fact that we are primarily now dealing with a strain that is different than the strain that the vaccines were originally made against. And so I think the bottom line of the what the ACIP was reviewing is to say that um, if they are going to recommend that there is a booster dose, that it does need to be based on data, which they are going to have to review. And the way that they seem to be signaling that they were going to review this is to take a risk-based approach. And what they reviewed was some data in people 65 and up. They looked at 75 and up. They looked at residents of long-term care facilities, and they looked at healthcare workers. And with each of the groups, I think the considerations are slightly different, particularly for healthcare workers, where part of the concern is the healthcare workforce itself and wanting to protect the healthcare workforce and maintain a healthcare workforce. And then they were also drilling down on some of our most vulnerable folks. Of course, we already have recommendations in place for people that are more vulnerable, those with immune compromise. But now we were looking at the elders as well as long-term care facilities. And the data that they presented indicates that really there may be a case specifically for long-term care facility residents and those over 75 who may not meet any of the criteria for being immunocompromised. But again, they really were discussing more how they were going to approach this and what their framework was going to be. So they did not take a vote regarding the booster. That will be done at a future meeting. And they will actually be waiting, just like what they did with the additional dose, waiting for FDA authorization, which gives the regulatory allowance. Then they will be voting on what they are recommending as it relates to boosters. So we still don't know. They kind of, not only did they not sort of endorse the White House's booster announcement, they also questioned it a bit and talked about how it is creating confusion. It's creating confusion for just people in general, but also for healthcare providers who are trying to grapple with this information, particularly in light of Pfizer BioNTech receiving full approval. And in most cases, that does give some additional flexibility for off-label use, which I also talked about in the August 24th briefing. But they also talked about how this can exacerbate disparities, which is something we're very concerned about because you still have communities that are relatively under-vaccinated. And now when you make these kind of announcements, those who sort of have more access and maybe more wherewithal, maybe even getting over-vaccinated at a time when we don't have even vaccination rates. We still have pockets of places that are unvaccinated here in the United States and abroad. And all of this is happening in the absence of actual data to support a recommendation. So I think the bottom line from this was that they were not prepared to make a decision on the item. They're going to continue discussing it. They're going to take it up again in a future meeting where they're also going to review more data. So I'll be looking out for that. And that when they do make a recommendation, they really seem to be kind of gravitating towards this risk-based approach or a risk-based strategy that is going to take one by one sort of the highest risk groups that we're most worried about that should be prioritized for the booster. And that I think the biggest takeaway is that for now, our focus really needs to be on the unvaccinated, both here in the United States and abroad. And then they had actually a CDC spokesperson who presented briefly and kind of took it a step further to issue what I think amounted to a warning, saying that despite the Pfizer full approval, the situation that we're in now is different than with other medications or vaccines in that the COVID-19 vaccine is being distributed under what's called a provider agreement by the government through the CDC. And therefore, vaccine providers have to adhere to the requirements of the CDC and adhere to the recommendations of the ACIP and the FDA and adhere to the terms of their provider agreement. And so they, also reiterated the fact that the FDA has licensed the vaccine as a 2-dose series for 16 and up, and that for 12 to 15, they're operating under an emergency use authorization, but that essentially, despite Pfizer's full approval, that if vaccines are given off label, that the CDC is stating that providers could be risking. They could be risking basically being out of compliance with their agreement to receive those vaccines. So they could actually be in jeopardy of not becoming a vaccine administering site. They could lose whatever immunity or protection they have from claims. They also could be ineligible for payment. And I think also what I heard loud and clear and I thought was concerning is that a patient could be waiving their eligibility for federal compensation after an adverse event from a booster that has not been recommended. And so I know that there's just a lot of rumors that fly around about how nobody's liable if someone's injured by a vaccine, but that is just simply not the case. And in the case of the COVID-19 vaccine, there is what is called the Countermeasures Injury Compensation Program. And basically, this program, which is on the sheets that you get when you get your vaccine, has the phone number and website and all of that. That if you believe that you suffered anything from the COVID-19 vaccine, that not only do you submit that into the adverse reporting system, VAERS, but you also can submit a claim to the Countermeasures Injury Compensation Program. That is where claims are actually paid out of if there was indeed any kind of an injury. And it's sort of a no fault system that is put in place when we have, like the current situation, a pandemic or an epidemic or even a security threat, and countermeasures are put into place, and then anyone is injured by those countermeasures. That is the Countermeasure Injury Compensation Program. And what the spokesperson stated is that patients could be not eligible for this compensation program. So even though we think that the risks remain very low, the safety profile of these vaccines has been very consistent. The ACIP simply has not had the opportunity to assess safety and need and to do that entire assessment. And so at this point, there is no recommendation. So I think what that said to me, and it was sort of the first time I had heard it laid out that way, is that this isn't the time to be rushing out for off label uses, despite Pfizer's full approval. I think that reasonable people and experts may disagree about one exception to this, and that is immunocompromised people who received the J&J as their primary series. It is rather concerning that we still do not have a recommendation for immunocompromised people who the ACIP, the CDC, and the FDA have all said should get an additional dose if their primary series was Moderna or Pfizer, but have not said anything about J&J. And I continue to be concerned about this and continue to be awaiting guidance. Remember, J&J came out later, so the ACIP has signaled that they need more time to look at that data, and maybe that patients also have more time because it hasn't been as long since they got their primary dose. Nonetheless, I think that there are many experts who themselves had received J&J who are saying, I'd like an mRNA dose as my additional dose. And I think that this is something that if you fall into that immunocompromised category and receive J&J, please talk to your physician about this. I think that is the most prudent route at this point. Certainly, if you fall into those categories, I think you already have a physician, but definitely if you are not connected to a physician, please get one and have this conversation. So the next thing I want to turn to is a little bit about the mandates, because we know that after Pfizer was fully approved, the mandates started really pouring in, and they are being issued left and right, and we understand why. The thought behind it is that people will be convinced to be vaccinated if their employer requires it, and we are certainly waiting to see if that is effective, if it's effective across the board. But I think it raises certain questions, so I'm just going to pose those questions at this point. And so one question is, will the mandates work? And so we know that exemptions are being allowed in some workplaces, not all. We know that there are fake exemptions happening. We know that there will always be profiteers. We've had no shortage of pandemic profiteers that will come out of the woodwork and make a buck off of all the situations. And so the question is will the mandate result in more vaccinations? Will the mandate result in more exemptions? And of course, if you get an exemption, that means you didn't get vaccinated. So that doesn't really fulfill the hope and the promise of the mandates. And it's very likely that, of course, it's going to be some combination of the two, and that how the distribution is between people who are convinced to come get off the fence and get vaccinated, or get pushed to the other side of the fence and get exempt and try to proceed with an exemption. We just don't know. It's likely that that will look different in different groups, different age groups, and different socioeconomic groups, and depending on all of the other different factors that people need to consider for themselves. The other question is, will mandates lead to more unemployment, and will there be disparities there? So I leave that question for all of us to consider, given that one of the things that has happened during this pandemic is that we have had um, quite a bit of economic stress on our communities, and this is not necessarily even. But would the mandates then further exacerbate that situation? Something for us to think about. Next question is, will mandates lead to labor shortages? And this is particularly of concern in already strained sectors like in healthcare. And so that is something that will just remain to be seen. We're also wondering where prior exposure plays into this. So, as we talk about exemptions, one of the, I think, legitimate questions that people who've had infection with COVID are asking, if I already probably have antibodies, I've already been exposed, I think I might have natural immunity. Do I really legally need the vaccine? Now, clinically, the evidence seems to be very clear that the safest way to go is absolutely to get vaccinated after having had COVID, simply because, first of all, there are a number of studies, and they all are conflicting, and they all have so many confounding variables in them, including people's behavior, how long ago they caught COVID, how long ago they were vaccinated. So these are not anything head to head, unfortunately, to this point. But we know that for those who survive COVID infection, and not everyone does, remember, about 1 in 56 die from COVID. So for the others who survive, their natural immunity can be robust. But it's just about as unpredictable as COVID itself. And so we know that the only way to get natural immunity is to get COVID and live, which means, you could have serious illness, you could have long-term side effects, and, again, you risk death. And so this is not something we should be attempting to try to do, get natural immunity by any stretch of the imagination. But we know, again, that we have millions of people who have had COVID-19. And so even though clinically we know the recommendation is to get the vaccine, we understand that this may pose a legal question. And so we do wonder whether exemptions will be considered at some point for those who have recovered from COVID-19, particularly if they can demonstrate immunity. And this leads to my persistent question, which is, when will we have a test of immunity? And we know that these tests are possible. They may be difficult, they may be expensive, but I do think it's important that we be able to assess immunity so that we can better tailor both our clinical recommendations and our legal mandates alike. And I think the last question really has to do with what we are seeing as a trend of some school districts that are requiring vaccination for attendance. And this brings about a number of questions. The first is that we are still operating under emergency use authorization for 12 to 15-year-olds. So we certainly have questions about mandating in this setting. We know that most of the mandates really came about after full biologics license. So that is just something to consider. We only have that for Pfizer for 16 and up. And really, I think the bigger question is how this may impact disparities in education. Our children do have a right to an education, and we know that children aren't always the ones making their health related decisions. And so the concern would be Will we deprive students in an inequitable way from education, oftentimes based on factors that are out of their own control? And what will be the end result of that? So these are just some things that we are contemplating as things continue to get more and more complicated in this area, and things that we will continue to keep an eye on. And so, as I alluded to in the beginning, I think the goal of herd immunity is feeling like something maybe many of us are just sort of letting go of, and realizing that that just might not ever happen. And that at this point, our goal is to get out of the current health crisis, get out of this active and evolving pandemic, and get into a situation where COVID-19 is endemic, which means we live with it essentially. And so this is not welcome news by any stretch. It's also still maybe a little bit in the realm of opinion, but based on how things are going, I think it's an educated opinion. And so, what do we do? I think that a lot of folks have been feeling a little down, depressed about this. And, I think it's because we're all having to undergo a big shift in our thinking about how we manage this. And so part of it is really, how do we live with COVID and what things can we do? And we talked on this briefing many, many times about doing our own risk benefit analysis. What things can we feel comfortable doing, not comfortable doing? We understand all the basic principles around being outside is safer than inside, and being spread apart is safer than being close to one another. Being together for a shorter period of time is safer than long period of time. So, what things can we enjoy doing outdoors? How can we assess our indoor environments to make sure there's as safe as possible? I know for myself, I have definitely been trying to just start to reintroduce activities, but make sure that they're outside, and that that's something that can be sustainable and do for a long, for the future, if that's what needs to happen. For indoor spaces, we don't always have a great way to assess ventilation, but my new favorite tool is this carbon dioxide monitor. Remember that carbon dioxide accumulation is really a proxy for ventilation, because carbon dioxide can't accumulate indoors if you have good ventilation. And so outside, you're usually looking at between 400 and 500 parts per million. Safe indoors is probably around 800 or lower. And, I started taking this around with me to different places, and it's been very interesting to see how small interventions sometimes can make a big difference. You could get in your car with your windows closed and no air circulating, and just watch the carbon dioxide accumulate and those numbers go up. And by just cracking open the window, you can see it start to come back down. So it's an interesting tool. Probably not so much to take to your favorite restaurant and take it up with the manager, because again, these are things that are challenging to create adequate ventilation in different spaces, but more for you to know for yourself what's going on, and also to test out different interventions like opening a door, turning on the air, opening a window, etc. So these are just some things that we might want to think about in terms of living with COVID, and how we can assess some of our indoor spaces. And we'll be talking about more ways to kind of live with COVID as we go on. Right now, because we are still in an active and evolving pandemic, we all need to be exercising vigilance. And this is whether you're vaccinated or not. If you have symptoms, get tested right away. Remember, symptoms can look different if you're vaccinated, and Delta also looks a little bit different. So keep in mind, it's not just going to be cough and shortness of breath. We're looking at headache, sore throat, runny nose, sneezing, and of course, loss of taste and smell is COVID until proven otherwise. And if you get those symptoms, get tested right away. If you believe you were exposed, then also isolate yourself, get tested in about 3 to 5 days, and continue to isolate until you get your results. If you test positive, please do what you can to get your close contacts to be tested and isolate themselves as well. If you are positive and believe you are in a high risk category for doing poorly with COVID-19, please inquire about monoclonal antibody treatment. And for everyone, to optimize your immune functioning, take a multivitamin supplement, consider additional vitamin D supplementation, manage your stress, and get a good night's sleep. If you have any questions or topics you would like us to cover, please leave them in the chat or email us at admin@rootsclinic.org. This concludes today's People's Health Briefing. Thank you for joining us. Please tune in next Tuesday at 10. See you then.